So now I'm going to talk about strategies for radiologists and technologists communication and improving that. I promise this lecture will be shorter. There's not quite as much we want to be brief. So I have no relevant disclosures. So why is communication important? So we all know that we're much more technically more isolated than we used to be. I used to sit in a reading room that was right next to the CT scanner. And if I had any issues or anything I wanted to discuss, I could just walk over and talk to the tech. I knew all the technologists. And now we often are working in a remote position, a place that's remote from our technologists. So we don't see them as often. And then there's less collaboration. And with less collaboration, with not knowing each other and seeing each other as often, there's going to be more communication errors. And that can lead to more medical errors, in fact, when the Joint Commission reviewed the Sentinel events that were reported to them, what they found was communication was the third leading cause of medical error. And here, most events have multiple root causes, so this doesn't add up obviously to 100%, but communication was present, errors were present in almost 2/3 of the cases that were reviewed. So I think often we don't realize when these communication errors occur. We think that we've communicated what we've communicated, but it wasn't received in the way that we thought. So what I'm going to talk about today is what barriers there are to communication. I'm going to describe the attributes of what is effective communication. We're going to talk about using team steps, which is a team training modules that are presented by the AHRQ, and use their modules for strategies for effective communication. We're going to learn how to give effective feedback effectively. And then we're going to talk about the different methods of communication, the asynchronous and methods, as well as for non-urgent communications. So I want to ask you to consider, as radiologists, to consider a few things when you're talking to technologists. One is that we should make a good faith assumption that we're all here for the same reason. We're here to take care of the patient and to take care of them well. We have to realize that there's a power differential. So as we just discussed, many of the technologists are not used to speaking up or feel are afraid to speak up because of that power differential. And then I also want to emphasize that we're in a learning environment, or we should be in a learning environment. So every time I get a call and I'm asked to make a decision, I take time to explain why I made that decision, and I make sure that I check for understanding and make sure they understand why I make that decision, and what the procedure, what they have to do next. And same with the technologists, I would say same thing. Good, make a good faith assumption that we're all here for the same reason. If you're in a place that has trainees, or if you have new radiologists, they may not be familiar with the protocols and procedures. So they may not know why you're calling them or what you're asking them. So it's important to be clear. And if there are choices to be offered, you can offer those choices. That makes it easier for people to decide. And it's the same thing with radiologists. If there are choices to be made, we can offer the choices when possible. So there are a lot of barriers to effective communications, or distractions. I mean, that is a major barrier to effective communication for both radiologists and technologists. We are constantly distracted. We're trying to do our read our studies, or we're trying to scan our patients, and we get this phone call. We're a little distracted because we're trying to do two things at once. That's a major barrier to effective communication. I already talked about hierarchy being a barrier to communication. That physical proximity, we know that 70% of what we communicate is in our body language, and we don't have that when we communicate through the phone or through a text message. There are different communication styles. Some people are very short, and other people may take a little while to get to the point. So there are different ways that people communicate, and that can be a barrier. Shift changes are a barrier. You may have communicated to one person, you think that you're communicating with the same person, when in fact there's been a shift change and now you're talking to somebody new and they don't know what you're talking about. Lack of information verification. We don't often check back to see if what we thought we communicated was received in the way that we expect. So checking back for that information is important. And then there's language barriers. And in medicine in particular, there's one of the language barriers is the use of abbreviations. I have a really funny story from when I was a medical student. I was on a surgery rotation, and these surgery resident asked me to write down we were putting together the sign-out sheet for the next day, and he told me to write down that this patient needed a soft dill. And I said, "What was that? What did you say?" And he said, "Soft dill." And so I wrote down, he asked him 3 times, and I wrote down soft dill because I didn't know what else to do. I asked him 3 times what it was. And it turned out he meant esophageal dilatation. So abbreviations are, just make sure that people understand your abbreviations, or just don't use them when you're talking to people. The last thing is workplace culture, that sense of, is it safe for me to speak up? And that's what psychological safety is. It's the sense that if you speak up, that people will give you the benefit of the doubt. It's a little bit different from trust, where you're giving someone the benefit of the doubt. You trust somebody to take your ideas. But psychological safety is the environment. Are you in an environment where you feel safe to speak up? And this is really important if you want people to communicate with you. So as I said, some of the communications, like all the communication strategies that I'm presenting here, are part of the Team Steps training. And they're now actually at Team Steps 3.0, but this is you can use this link here to get to it. It's great because it's free. There's all these downloadable slides and instructor guides, so you can get a sense of how to not only the information, how to present, but how to present it. And there's a bunch of video examples. Some of them are really cheesy. Hopefully they've updated them by now. But there's some video examples about how to how to use some of these strategies. So to communicate effectively, that communication should be complete, concise, clear, and timely. Complete, concise, clear, and timely. So we don't, we want to make sure that communication happens when it needs to happen, that it provides all the information needed for decision making, that it's not too long-winded, because people lose their attention span, they get distracted, and then you may not have heard what the other person was saying, and that it's clear that we are saying what we think we're saying. So the strategies that I use with communication, the one that I use the most often is SBAR. That's situation, background, assessment, and recommendation or request. I use this all the time. It's so ingrained in how I communicate that I don't even think about it when I use it. Callouts are used during emergency situations when you need everybody to know what you're doing at the time, or to understand if there's a piece of information that everybody needs. And the check back is that information verification. Another thing that's really important for effective communication is mutual support, that psychological safety, so that people can advocate and assert when they need to. And we'll talk about how to start a discussion for when you're advocating for your patient, and the 2 challenge rule of speaking up and asserting when you don't agree with the decision that's being made. So SBAR is situation, background, assessment, and recommendation or request. I think most often when I'm talking, I've trained technologists to use this, but the thing that they often leave out is the assessment, because they don't feel, I think they just don't feel that they have a say in how or can give you their opinion. And this is something that I really want to emphasize as far as, trying to get your technologists to be more comfortable with providing their opinions. And some of them, it may be that they're new and they don't really know how to assess the situation. But, there are people who've been around for a while that I was surprised often did not give me an assessment because they didn't feel like they, that their opinion, that what I wanted their opinion. And I want to know what they think about the situation. So here's an example of SBAR from a tech perspective. I just did a CT chest on an outpatient with dyspnea. She has a history of lung cancer. I think she has a pulmonary embolism. Could you look at it and tell me what I should do with the patient? Very simple, very short. I use this whenever I talk to a referring clinician about something I want to communicate with them. And it's just so automatic now. I just think, okay, what's this patient here for? Why did they, what kind of the background? Because, when we're calling these referring clinicians, they're not necessarily going to have that patient at the forefront of their mind. They may not remember this patient. So I make sure that I give them enough information so they can make a decision. And the best thing to do with SBAR is to practice it as a team. So, I mentioned that we had these retreats for our CT technologists. And the last retreat I did at the University of Utah, I asked some volunteers from the residency, my residents, to come up to the meeting and practice doing SBAR with the technologists and give them feedback. So I gave them some scenarios to work with. This one really works well with the last talk. Patients here for head trauma, and they don't want to. They're worried about getting a CT because of radiation. What would you say to the radiologist? What question or recommendation would you give? So it's just practicing these scenarios gives them an idea of how it's to be used, and getting them and gives them a way to give them feedback on how they're using this strategy. So a check back is a verification of information. This is repeating back the pertinent information to the person that gave it to you. For example, just checking back on a protocol that you wanted. You want the pulmonary embolism protocol, but also a venous phase to look at venous clot, and just repeating back what you heard in that conversation. And I do this myself automatically a lot of times, especially when I'm making an appointment for myself. I make sure that I heard the date correctly and the time correctly, so that there's no miscommunication and I don't put things down in the wrong place in my calendar because I will not show up. And then there's the call out, which is a way of quickly communicating critical information especially in an emergency situation, and it informs the entire team at the same time and helps the team anticipate the next step. So, for example, if you had a patient with a contrast reaction, and that now you see that patient is more short of breath, you might want to say, hey, this patient is becoming more short of breath, so I'm going to give them epinephrine. So you take out the epinephrine and give it to them, and that prevents somebody else from doing the same thing, and gives people critical information that you're giving them a drug. So now I want to talk about mutual support. So this is the psychological safety and in giving people feedback about their what they've done and how they can improve. And that's part of team behavior. And also the psychological safety to assert and advocate for your patient. So let's talk about feedback first. So what's the purpose of feedback? Is to improve team performance. So we have to think about it as improving team performance. It's not to punish somebody. It's not to tell them they did something wrong. It's to make sure that we're learning to improve what we're doing. So that's an important thing to keep in mind when you're giving feedback. And it's important that the feedback is timely, that we're not saving it up for later, that it's respectful, specific. So concentrate on what actually happened and how that affected the team or the patient. And then a good way to do is to say, to say, what do you think we can do to prevent this from happening in the future? So again, directing that feedback towards improving for the next time. And also, talking with consideration. And these seem like they're very simple things that we should know what to do, but I think in the heat of the moment, sometimes we have to take a step back and think about how can we make this feedback constructive and such that we can prevent problems in the future, and not just because we're angry that it didn't, not the right protocol wasn't done. So with feedback, real time is usually still best especially for any safety or quality issue that might require immediate reaction. But we know that people are busy, and we may not be able to reach the technologists in time or give feedback in a timely manner because we're both busy doing other things. And so for non-urgent feedback, there are other ways that we can provide that. And one way is to use a QA system. And I know a lot of places have this now. Every place I've worked at, we've put in a QA system. I started one at Emory when I was there. We had one at University of Utah that was like this, where we submitted a QA issue in PACS. The supervisor reviewed the submission, discussed it with the technologists or correct the problem if they could. And then we reviewed them at a monthly meeting. If there was more information needed, we would go back to either the radiologist or technologist, ask them to clarify or to find out more about what happened. And then we made any corrections that we needed to do, and then that information, the disposition on that would go back to the radiologist. So this last step is important too, because we want the radiologist to know that what happened with that case and that information was received and that something was done with it. So one of the when I implemented this at Emory years ago, I sent out a survey afterwards to see what the technologists thought about it. And one of their concerns was that the radiologist didn't give it specific information or suggestions. So I think as radiologists, if you're asking somebody to make a change, if you're saying that something was done incorrectly, you really need to know what the correct thing to do is, or at least make a query about, could we have done it this way? Could we have done it that way? Those things are really helpful. And they also complained that they would rather receive the information directly. So I think this is that there has to be a balance between receiving information or providing information via these systems and then talking with people directly. And sometimes it's easier to do that than others, but making an effort to do that on occasion, I think is helpful. Now we're going to talk about advocacy and assertion. Again, this goes to that question that Dr. Byman had about how do we get technologists to speak up for their patients and for themselves. And again, having that psychological safety, an environment where this can be done, and speaking up in a respectful and firm manner is how to do that. So there are 5 steps you can take to advocate for your patients. Open the discussions, state the concern, and really spend the time talking about the factual, the things that happen and the concern that you have, what the problem is that you think is. Offer a solution. I think that's really helpful, is to, whenever I bring up concern, I bring up possible solution, and it may or may not work. but at least I thought about what we could do to address the problem and then obtain an agreement on that. So one way that we can advocate for our patients is using the 2-challenge rule. And this is something that has to be understood by the team. This is invoked when your initial assertion is ignored. It's your responsibility to assertively voice the concerns at least 2 times. So if you bring up something, for example, that in that last scenario that I talked about, where the technologist tried to stop the procedure from happening because she knew that it was the wrong side. If they had ignored her, I mean, it is expected to bring that up again and challenge, bring up the concern again and say that this is, I'm concerned about this patient because you're doing the wrong side, and that person who is being challenged needs to acknowledge that communication. So I think that it's important, again, to establish this as a something that we do when we're advocating for our patients. We're not trying to be disrespectful, challenging people. We're trying to advocate for our patients, and we're going to continue to advocate if we think that it's necessary. As a radiologist, if I were being challenged and I didn't agree, I would explain my reasoning for not agreeing, rather than just saying no. Let's just do it because I said so. I think that's just common courtesy and the way to deal with this sort of thing. So different methods of communication, what ways can we communicate with people? We talked about like urgent communication, such as an acute finding, those require a call. But there are also non-urgent issues like protocoling a study. You might want to make a call for that, but you could also do some instant messaging. A lot of places have some kind of instant message system. Make sure that it is HIPAA compliant if you're going to use it. At NYU, we use Primordial. In my previous institution, we used Teams because that was HIPAA compliant, and everybody had it. So some things can be done that way, and just as with texting that we're very used to using texting people now. It's not always convenient to make a phone call. Sometimes it's more convenient to text people. Then finally, the feedback for some things that are some problems with the scan that are not urgent, you may call if it's urgent, or instant message, or use a QA system if it's something that is non-urgent. So this is an example of a instant messaging. This is communication that I have with one of my technologists about a TAVR protocol, and she was able to send me images of what was going on, like a screenshot of what she was doing. So it was a really convenient way for me to address this without having to be there. And she was at a remote site, so there was no way I could be there to help her. But having her upload some images made it a lot easier for me to deal with this question. So one of our residents at University of Utah implemented instant messaging because we weren't using it initially for their evening and overnight shifts. So he did it as his QA project or a QI project because the residents at night got a lot of calls, and it was really challenging to do their work because they were being interrupted so frequently. And you can see here before the messaging system, they found it really challenging to get their work done. They estimated the frequency of calls to be 16 to 17 in an hour, which is a lot. That's almost one every 5 to 10 minutes. So with the utilization of messaging, that went down to about 8 an hour, which is a lot better. And most of those calls were from the technologists. And when they implemented this, they implemented, had the CT and MR technologists using the instant messaging. They hadn't had all of the modalities start using it yet. And even with that, it reduced the phone calls by nearly half. The residents really liked having this system. They thought it was easy to use and it was an effective way of communicating. With the technologists, they were a little more wary of it because they, instead of getting the answer right away, they sometimes had to wait a little bit. So it was a little bit more of a they were a little less satisfied, but still pretty well satisfied with the process. And the residents didn't think that it caused any delay in patient care, and the technologists in general agreed with that, although a few thought that there was delay in patient care. So I think it can be safely implemented. There may be necessary to reinforce what sort of things get calls on, because you don't want to call for every single thing. Things that are more urgent would still require a call, but there are issues that you can probably address using instant messaging without having to make a phone call, and it would probably not affect any of your patient care. So in summary, communicating effectively is make it complete, concise, clear and timely, building in that psychological safety in your team so that there's an understanding that when people bring things up, it's well received. The different methods of communicating, or different strategies for communicating in different situations. SBAR for most communications that I do. Check back so that you can review what your what was just communicated to you, and the call outs for emergency situations, and then having that expectation of advocacy and the 2 challenge rule, and the different methods of communicating we talked about as well. So I'm going to stop there and answer any questions.
Thank you for another terrific presentation, Anne. I think such important material. I think we need to really enhance our communication, which hasn't been so great. I think we have a history in medicine of having a very hierarchical structure, which doesn't necessarily enhance quality patient care. So there are a couple of questions in the Q&A. The first is whether there are automated QA systems. The person who wrote in said, we've been using a QA system built by an employee, and the biggest problem was that it depends on 1 or 2 people hand sorting who gets sent which QA, and that's a huge problem.
Yeah, there are, okay, so I know the 2 places that I worked at. One place we used, our risk system had a QA system that we could use. So we just used what was there. As far as routing on the back end, there was some way where our IT people were able to route them to the correct people. But I feel like a lot of these are homegrown. I know Primordial has a way that you can have QA built in, but a lot of these systems are unfortunately homegrown. I don't know if anybody else knows of QA systems, but I think that the one I used at NYU now is homegrown. It's excellent. It routes it to the right person. It's all customized questions, so we fill it out and it gets done. But it's not. I don't think there's one.
Anyone who knows of a good system, please share it in the chat with all of us. The next question wants to know if you've considered publication of this very important strategic topic for managers, radiologists, radiologist-technologists, nuclear medicine personnel, CT, ultrasound mammography.
Yeah, I haven't published it, but Lane Donnelly has an excellent paper in Radiographics about the daily management system. So I would refer you to that paper. It's in one of my talks. So if you, in the previous talk, so if you go back to one of my slides, it has Lane Donnelly's. It's from 2014 in Radiographics. So yeah, it's been published out there. It's just I haven't done it myself.
Fantastic. The last question is, what happens when a physician routinely uses 4-phase studies on patients we're ruling out kidney stones or appendicitis.
Oh,
How
wow.
does the tech communicate their feelings that the assignment of the study was not optimum? It's not, it's a fundamental disagreement. It's not a misunderstanding. But
Yes.
what's being asked, I agree, is in the category of unsafe care.
Yes, I think this is something that is a little bit more difficult to deal with, right? So um maybe this is where you would bring it up to a section chief, to discuss about when these things are done, and why they would be done this way. And it's really hard for a technologist to make that, but I think you can get an advocate in the section, most likely, or with your CT director. And that's exactly what happens when I was CT director. Was I've had technologists saying that they think that some of these studies, we have too many images, that we're doing too many phases. Can you talk to the physician about it, or to the section chief about it? And I've done that. So if you have a CT director, that's probably the best person to address those issues. It's certainly not something that it would be difficult for you to address on your own.
I agree. It's sort of, that doesn't need to be fixed in that moment. It needs to be fixed for all the other
Right.
moments. And so having a conversation after that exam is done, hopefully with someone in a leadership position who agrees with you that this is not ideal, and then elevate the issue, which you said
Right.
works very well. The last question, you can have 1 minute to answer, is how to handle disagreements with a fellow colleague, lead professionally, who may not be thinking scientifically and objectively. How should we deal with fear of offending people while speaking up and expressing our thoughts in a positive, suggestive way, or identifying negatives as well?
Yes, I think that goes back to keeping it very factual and about the thing that you're trying to improve. And it's funny because my son just experienced this. He's 17. He brought an idea to his robotics team, and the person, the student that was kind of in charge of that, was really defensive and said that now you're not going to work on any of these things. And he had to, he said he tried to be as diplomatic as he could, making the information he presented very fact-based. So this is here's a paper that says this is not the right thing to do, and just really speaking to the facts. But some people are going to have that kind of reaction. So I think it's building that trust early on makes that information easier to receive.